Well, greetings again, everyone. This is Joyce Davis. I'm PennLive's Outreach and Opinion Editor, and we welcome you to another meeting of our editorial board. This time, we are taking up a most important topic, I think, for many people that relates to the cost of your medications and how they're determined. And there's such a convoluted method of doing all of this stuff. Sometimes it can be complex to the average person, but we have people who are coming in to talk about one aspect of this involving what they call PBMs, pharmacy benefits managers. And for most of us, we don't have a clue what that means, but it is very, very important. And to lead us in that discussion, we have Kate Kahn, who has brought in people who are advocating for some regulations around this issue. Hello, Kate. How are you?
Hi, Joyce. Thanks for everything, and good to see everybody. And we're happy to be able to present this to you. I think you're 100% right in the fact that most people don't know what PBMs are or do. So I'll do a quick little summary of that, and then introduce everybody who we've brought together who could add to um, sort of flushing it out for you and your
Well,
viewers.
before you get started, I do want people to know that we do have members of our editorial board here, Dr. Nirmal Joshi, as well as Rajette Harris, who is here. She is off camera, but we may be joined, and I will, as they come in, if later I will introduce them by other members. But the show is now yours, Kate. Take it away.
Thank you, Joyce. So PBMs, or pharmacy benefit managers, are the middleman between drug manufacturers and insurance companies and patients. And um, many insurers own PBMs, so they're all affiliated. It's sort of a vertical integration. And what most people don't know is that PBMs uh, pretty much determine the cost of your drugs. PBMs negotiate discounts from drug manufacturers, tell insurers which drugs to put on formularies, but those discounts are never passed along to the patients. And on top of that, PBMs and insurers implement protocols that can be really harmful to patients. Um, so I'll give you a quick example would be something called a copay accumulator, which is if you're somebody who has a copay assistance card from a drug manufacturer or a third party like an advocacy group, you go to the your drugstore, you are told you owe a certain amount, you hand over your copay assistance card to help cover the cost, and you're told, well, we'll take that. Thank you. Not by the, it's not the CVS, it's not the uh, people, the pharmacist who's taking that money. It's the insurer who's taking that money, but then they don't count it towards a patient's deductible, which is how it used to. That's the way it used to be. It would count towards a patient's deductible or out of pocket costs. That's just one example. So in essence, the insurer gets paid twice because they take the copay assistance card and they're still charging the patient for the full deductible. That's just one example. So there's legislation in various committees at the federal level to clamp down on PBMs, rightfully so, um, in the in the uh, in the effort to help patients, millions of patients, and certainly in Pennsylvania, thousands and thousands of patients. So, with us today to really highlight various angles of the issue, we have Maria Shoemaker, who suffers from a rare bleeding disorder, and she's faced some of these hurdles firsthand. We also have Chris Antipas, who is an independent pharmacist who owns several pharmacies in Pennsylvania, and is the board president of the Pennsylvania Pharmacists Association. And we have Haley Director, who's on the board of the Rare Disease, which is a national advocacy group. She's with Disease New England. And she can speak also to how it impacts patients, and Chris can certainly speak to how PBMs are undermining independent pharmacies, and patients. So those are our guests today. And Joyce, I'll let you decide who you want
Well,
to
yeah, because
first.
I will say this. I'm still a little confused at the first thing you said, believe it or not. And that is, and I've read about this now that so the pharmacist, I go with my card that, whatever off my, and this should, and you're telling me that I will give it to the pharmacist, but the insurance company will simply ignore it? Is that they're ignoring that
Oh,
card?
well, they're ignoring what it does for the patient. They're accepting that money,
I see.
and then they're still charging the patient.
The
So
full price of the drug.
right. So the insurer gets paid twice. And those are called copay accumulator programs. And 80% of commercial plans have them now. You probably don't know if your plan does because it's hidden down, I mean, what an insurance premium package looks like, and it's probably hidden down in the fine print somewhere. It may not be called, it may be called something else. And that's just
So fine.
one way that they are um, hurting patients. That's just one example of one tactic. Um, but there are many, many other tactics.
Well, let's turn to the pharmacist here. Chris, do you want to share your perspective on this? I mean, clearly you're a bit concerned as well, so share it with us.
Yeah, thank you, Joyce. So as Kate shared, so I'm a pharmacist. I'm a pharmacy owner. I have ownership in 5 different pharmacies in southwestern Pennsylvania. I also happen to own a pharmacy in Southern California. I am the president of the Pennsylvania Pharmacists Association, and I also wear another hat as a benefits consultant. So I work with a company here in Pittsburgh called Henderson Brothers, and I advise self-insured, self-funded employers on how to design their benefits for their employees. And my expertise lies on the pharmacy benefits sector. So I I have a very broad sense of perspective. My pharmacies include retail, compounding. I have a clinic-based pharmacy. I have a specialty pharmacy. So I'm touching rare diseases and then, traditional common diseases that affect many people. So that I think that foundation is helpful for the perspective. But basically, specific to pharmacy benefit managers, they sit in between many of the stakeholders in healthcare. So you've got the patient, the pharmacy, the provider, the prescriber who's writing the drug, the pharmaceutical manufacturer, uh, and the plan sponsor, which is where we often get hung up. When we say the term insurance company, we think insurance company is the entity that's paying the bill. And that sometimes is the case, but in other cases, there's actually a sponsor that's behind the scenes that nobody knows who they are. It's the employer of a company, for example. And so I think it's important whenever we talk about these issues to understand who is who and what are they
Mm,
actually doing. And the issue that Kate mentioned as it pertains to the accumulator, copay accumulator, I've seen this play out on both sides of the equation at the pharmacy counter for a patient, and then also as an advisor to plan sponsors who are trying to control costs. But overall, there's really just a lack of transparency in how these issues are managed. And patients are often highly confused,
yes.
and they are sometimes left in a scenario where because they don't understand how things are going, they walk away from the pharmacy counter without medication. Then you have gaps in their care. Now, I mean, I have opinions on the utility of copay accumulators, which one of the outcomes of a copay accumulator program is that a patient will only get credit towards their deductible when they spend money out of their own pocket versus how prior to accumulators, if you have a deductible, if a drug manufacturer covers your copay through the assistance programs that they put out to help patients, in some cases, patients were getting credit as if they paid that deductible themselves, but they didn't actually come out of pocket. The drug manufacturer assisted them and they were getting credit. And so this is where the issue lies that Kate specifically referenced. It can benefit the plan sponsor, the insurance company. It definitely hurts patients for sure. I would say that more broadly, when we speak about pharmacy benefit managers, the challenge that we face with those companies is they possess great control, as Kate said, over drug pricing. They will oftentimes cite drug manufacturers as the ones who set prices, but they don't disclose that they are retaining a percentage of that drug price, and the more of that they retain in their negotiations with drug manufacturers, they basically force the market to inflate pricing to account for the backdoor payments that the drug manufacturers are getting. And in and of itself, that seems problematic. But when you, again, as Kate pointed out, when you factor in that these organizations are vertically integrated, they own multiple layers of the supply chain, they begin shifting patients to businesses that they own. It's as if, you know, in Pennsylvania, a doctor is not allowed to own a pharmacy because we don't want the doctor to tell a patient they have to go to the pharmacy that the doctor owns. But the pharmacy benefit manager owns pharmacies, and they're directing patients and forcing them to use the pharmacy that the PBM owns, and they're paying their pharmacy at a much higher rate than they're paying my pharmacy. And so there are anti-competitive practices. Again, we could spend 8 hours talking about this, and your brain would swell with the complexities of it. And so I don't want to take us down, I don't want to totally derail this conversation, but we can kind of dig into specific issues that are problematic. The overarching theme is that the pharmacy benefit manager has tremendous power, control, and influence, and they possess conflicts of interest that will taint or poison their actions, decisions, recommendations that will benefit them at the expense of patients, plan sponsors like employers, and especially pharmacies that compete with them. So I'll pause there and
Well,
have
that
provide
certainly
additional
shed a
context.
little more light on it and clarified things a lot more for me. I'll come back because we now want to talk about, you know, who's regulating this, whose job, I mean, who's keeping these people in check. But before we do, I want to hear from Maria because she is a patient. She's directly influenced or at least impacted by all of this. Maria, let's hear your view on it.
I got my first taste of this at the beginning of 2022. My husband had changed jobs, and we were, unbeknownst to me, because the language is very obscured in the policies, and even the policies that have the language, not all of them actually do enforce that. So you don't know until you go to get the medication whether or not they're going to enforce it or not. When I went to get my medication, I was told you have to sign up for copay assistance to get it. I've been signed up for copay assistance for years. They always help a portion of my deductible. I never have had it fully paid, but a portion of the deductible. And as somebody with health problems, deductible out of pocket, that is just a drop in the bucket of our medical costs. We have all kinds of aids, supplies, home assistance, vehicle assistance things. Our expenses are through the roof. But anyways, I digress. I found out I was under a maximizer. They told me to call this company. I called them. They said in order for me to get my medication, I had to give this third-party company, whom they would not give me an address, phone number, names of anybody that lived, of where this place was, anything. No specifics. They would give me no information, but they wanted access to my full medical history, and they wanted ability to come to send people to my home to check my on-hand medication supplies. And I said, whoa, wait a second. I don't know. I'm very uncomfortable with this. As soon as I said no, they locked me into no. And for the next 15 months, if I wanted to gain access to my factor medication, which is $12,000 a dose, and I can use up to 3 doses a day if I'm having a bad bleed. On average, I use 3 to 4 doses a month for my period. I had to pay out of pocket 100%. They would not cover it for those 15 months because they locked me in as no, I was not signing up for that program, and my medication was excluded from the plan. In order for us to finally get me coverage again and get me back on my medication, my husband had to change jobs, which thankfully, with him being an engineer, he was able to. But even with the new job, we didn't know going in because it had the exact same language. It calls them coupons, which is ridiculous because they're not coupons. But something a lot of people don't understand is people that get patients assistance from the drug manufacturers. The majority of the times when they offer these programs, it's medications that have no generic equivalent. And I know in my case, even if they took every drop of penny away, every drop of profit away, and just went based strictly on what it costs to make this product, which is plasma based, so they need donors, they need to screen the donors, then they need to chemically treat, pasteurize, freeze dry the product. It's expensive. And that's for the cheaper of the version. If I go with the recombinant, we have brilliant scientists actually making these molecules in labs for me to be able to survive. And during the course of 2022, I paid over $12,000 out of my pocket on top of my on top of my uh the premiums that we pay every pay for my husband's pay, which is almost $500 a month. We spent over $12,000 and still I was not able to access my medication. And the worst part is I couldn't do like a fundraiser because I mean, I could get my medication. I could raise enough funds to pay for my 3 doses, which was $57,000. But even that $57,000, if I did not pay it directly from my pocket and did not provide proof that it was my own money, it would not count against my almost $9,000 out of pocket deductible.
Hmm.
So it was quite hard, quite
Wow.
traumatic. And I'm thankful that again, because of our place and our privilege, that we were able to ride out a very rocky year. But unfortunately, a lot of my friends in the community, a lot of people I know that have these health problems, they don't know this is coming. They don't even know that these things exist until they're hit with them. And when you are not expecting to be hit with a surprise $5,000 or $10,000 in medical bills, that can be ruination for a family. And like he said, in my case, I did forego care for 15 months. I went without 3 surgeries that I needed to have. I had to put on hold because I could not get them done. I had to go in for 2 IV iron infusions because I was bleeding so much and didn't have the factor to help me stop with the bleeding. I was in the process of returning to school. I was going back to go for accounting when this happened. I had to pause my schooling because I was too sick and too fatigued to go to school. I hear so much from people saying, well, you're deductible, you're out of pocket. That's your skin in the game. We want to make sure you're doing what you need to do to stay healthy. But the thing they don't realize is my ability to get up and move, my ability to survive is all the skin I need in my game. Without that medication, I can't do it.
Right.
I can't be a contributing member to society. We're back in the times, thanks to PBMs. I have friends of mine that are again now refusing to get married because of the risks of going on a spouse's insurance and the risk of the copay, the PBMs coming at us. And oh, it's a nightmare. Ironically, my husband and I even discussed getting divorced ourselves, and we were high school sweethearts. We met when we were 15. But we were very close last year to getting divorced when it was either he could find a job that would get me the factor or we had to get divorced so I could get state insurance.
I see. Wow. Well, that certainly I am sure has touched all of us. Your story, that's something. I want to come back to what you're proposing be done about it, but I'm going to open it up now because I know Dr. Joshi has some questions for sure, and Reverend Strauss. So, Dr. Joshi, why don't you start? Because I know you really do want to delve into some things here.
Yeah, no, I think that I'm just trying to understand. I mean, the process I understand. The process of PBMs and the roles they play. Since Maria's story is very personal, and I think it's not discounting the fact that it's intensely personal and something that impacts her every single day. So I want to obviously very strongly acknowledge that, but also want to use this opportunity to understand. So the questions that I'm asking Maria right now, Maria, they're not meant to kind of open the story. They're meant to understand that how what Chris outlined connects with what you described as a human story, right? So it's in that frame of reference that I'm asking you some of the questions. So in your case, so let's say your deductibles, whatever. Let's make up a number. Let's say your deductible was $10,000 for the year, right? All in any health insurance, and your medication costed. I'm making up a number again, $60,000 a year. It's actually more than that, significantly more than that. But if it's 60,000 a year, um, notwithstanding everything else in the pharmacy process, does the deductible not cap at a certain number for you, and then beyond that it's the insurer's responsibility, or that's not the case?
It does cap in certain instances. However, we're finding that again, since we had the law change and the protections put in place, the ACA laws to give us protection with prescriptions and everything else. Again, insurance companies, their only legal obligation is to their stockholders. Their legal obligation, their fiduciary responsibility is to their stockholders to make money. So their job is to find loopholes and wiggle room and anywhere they can. And their logic behind this is that especially things that are not traditional medications, not like amoxicillin, things that are actual biologics, do not count as prescription medications and are not granted coverage under ACA. So they are able to now exclude those
Got it. That answers my
from
question.
coverage.
That
That's where the problem lies. So if I would have said yes to the company in the beginning, they would have allowed me to get my medication. It would have cost me nothing. I would have still had my $3,000 deductible and my $6,500 out of pocket that I would have had to have met.
So that was my other question. So thank you. That answers the first part of my question, that there's a carve out for highly expensive medications, highly
Correct.
unused medications. So that gets it out of the main process. Now, the other part of the question, again, to understand the process, is what were they asking you to sign that would have made it? I lost that kind of train of thought there.
In my case, the PBM worked with this company called Save On SP. And Save On SP wanted me to grant them permission to collect the copay assistance on my behalf from the pharmacy company.
Okay.
And in order to do that, they wanted my personal information, they wanted access to my medical records, and they also wanted access to my home. And myself, my husband, and our 5 children were just part of the most recent, well, at that time it was recent, now it's a few years old, the Highmark data breach, where all of our numbers were released. I myself was a victim of Social Security. My Social Security number was stolen, and I had over $44,000 in credit cards ran up in my name that I never knew about. So I was very apprehensive on that part of it, and I had no idea what copay maximizers, accumulators, very little knowledge about PBMs were at the time. So my initial gut reaction was, no, 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 I'm not giving you permission to anything yet. I want to find out who you are and what you want.
So who were they, and what did they want?
That is a darn good question, because when I asked who they were, they refused to give me anything other than a 1-800 number, no address, no employee names. They sent me a 1-page email that said, these are the drugs that we help you get. And that was the only information that they would give me. My husband's employer refused to, well, In our case, we had a plan that, as the pharmacist said, some plans, you have the insurance companies paying, sometimes it's the employers. My husband's plan at that time was an ERISA plan, so it was his employer that would actually end up paying the bills.
Yeah, okay, I got it. So basically, your understanding was that there are some third party that's trying to work in a similar fashion like a PBM would,
Yes.
in concept, and somehow make money out of this very sad situation to kind of make money out of these, what I'm broadly calling specialty drugs. I know specialty drugs are, kind of even at a lower threshold, much lower threshold than what you are talking about. But broadly, they would classify specialty drugs, and that they would make money out of it. If they were able to, your cost might get zero and they walk away with a bunch. The drug company walks away with a bunch.
Well,
and yeah.
They'll tell me my cost is zero.
Yeah.
But again, in my case, the drug company that I used at the time offered $20,000 in manufacturer assistance. I never used anywhere near that in historically. Never, and maybe around 2000, if that.
I got it. I think I've understood.
Yeah, once that changed, they wanted to collect the full 20,000 from the insurance company, plus come at me for the deductible and the out-of-pocket, which was another 9,500 on top of that 20,000.
And this next one, and then that's all I need to know, and then I think we can move on with the conversation, which is a very interesting one, which is that before you get into what are you proposing, I guess I'd love to know each one of your collective interest in this. Where are you coming at it from?
I can start.
Not Maria, not you. I meant the others on the call.
Yeah, I can start. Just so everyone knows me again. Hi, I'm Haley. I am the policy director from Rare New England, which is a rare disease nonprofit operating out of New England. I'm also a PhD student in health services research and policy at the University of Pittsburgh School of Public Health. So I think that my interest in this comes from, similar to Maria's story, we have a lot of people who aren't able to afford medications because of these high costs. And as Chris mentioned, there is a huge monopoly, or an oligopoly. 3 companies own 85% of the market, which, as Chris said, reduces competition. It drives up costs. So obviously everyone needs drugs because people get sick and there's a lot of issues people face, especially in the rare disease community. There's a lot of orphan drugs and drugs that are specially made for those patients that sometimes aren't covered by insurance. So a lot of times those costs are super high, and anything that affects drug costs affects everyone. So lowering prices is super important just to ensure access and continuity of care, as Chris and Maria both mentioned.
And Chris has already explained he's the owner of pharmacies, so he has a clear stake. And then Kate, I'm sorry, did you identify your organization?
Well, I'm with Gray Media. We're a public relations firm, and we work with a number of patient coalitions to raise awareness about these issues. And, when Haley said that 3 companies control 85% of the market, those are PBMs. 3 PBMs control 85% of the market. And
Kate, sorry to interrupt, in PA or in the country?
Nationally.
In the country, nationally, yeah. I believe the 3 are CVS, Optum, and Express Scripts. And they're owned by other companies as well.
What's the third one? Express Scripts, Optum, and who else?
CVS.
CVS.
Yes, got it. Thank you.
It's really CVS Caremark.
Yep, I got it. Thank you.
Mm-hmm.
And so they have an enormous amount of power. And because they don't face the regulation that other parts of the healthcare distribution system face, they have literally operated behind a curtain. They've been allowed to operate behind a curtain. And that's the problem. And these companies make literally billions of dollars a year in profit on the backs of patients and independent pharmacists. And Chris alluded to the pharmacist, you know, a little bit of the pharmacists, the unfair practices that happen when he said they pay independent pharmacists way less, and that's after steering patients to their own pharmacies. But there are hundreds of independent pharmacies that have gone out of business. And for many people and Joyce, you and I have spoken about this before, there's a lot of people in rural or underserved population areas, minority population areas, where those independent pharmacists are their main, if not only, healthcare touch point. And, you know, if we lose those, we already have pharmacy deserts all around, all across the country and in Pennsylvania and, you know, everywhere. The more it happens, the more power these 3 PBMs get and have, the more independent pharmacies you're going to see closing. And
As a
so
matter
that's
of
just,
fact, just for me to chime in real quick there, in January of last year, when I was finally able to access my medication, it took 23 days for Express Scripts to actually tell me that my prescription was not going to be authorized. It took them 23 days to run the prescription at the beginning of the month because, again, they have such a huge monopoly. They have so many people. There's no priority. If I would have had a major bleed during that time, I would have been in the hospital again. And the majority of hospitals in my area don't even stock the medication I need. So it would be quite a far drive.
Yeah,
I mean, it's
I can
and
speak to
again,
this.
I'm being mandated now to use that only pharmacy. If I want to get my medication, that's the only one I can go to.
So inherently, it's important to understand the infrastructure that drives the issues. So PBMs, when they sit in the middle between patients, pharmacies, payers, and drug manufacturers, they they bear no risk, basically. They will sign contracts that give the illusion of risk, where they agree to what they call an effective rate. The pharmacy world operates on discounts, basically made up numbers. So we know AWP, if you've heard of the term AWP, it's average wholesale price. Maybe this is less of a relevant analogy these days, but it's kind of like the sticker price on a car or the list price on the sofa at the furniture store. We realize that nobody really actually pays those numbers. You don't pay that. There's a 50% discount at the furniture store. It's like, well, I mean, 50% off of what? You can make up a number and take a 50% discount and feel like you're getting a good deal. That is basically how the pharmacy pricing world works. And PBMs negotiate an effective discount that they get across their network. Outside of that, there's really not even they don't even attempt to, say that they take risk in the marketplace. So and we've seen this. You don't actually have to even take my word on this. If you began to do some independent research on PBMs, conflicts of interest, you would find that the FTC has released a very long and detailed document on their grave concerns about pharmacy benefit managers and their contributions to increased patient costs, to increased plan sponsor cost, to the closing not just of hundreds, but literally thousands of pharmacies. Just in 2024 alone, we've lost, I mean, I think last I checked, as of halfway through the year, we had lost like 300 pharmacies in Pennsylvania alone. You have Walgreens announcing 1,200 closures. Rite Aid has closed thousands of pharmacies, or maybe more than 1,500 pharmacies. CVS is closing pharmacies. They just fired their CEO. The FTC is in a lawsuit battle with the PBMs. They're countersuing each other because the PBMs aren't happy about what the FTC is saying. You've got the Wall Street Journal, the New York Times that have run stories on this very topic of PBMs and their anti-competitive practices that drive prescription costs. And you can look at hours of testimony in front of multiple congressional hearings that are talking about this very issue. So I want to also stress, aside from Maria's personal stories and my anecdotes of my businesses and whatnot, this is not a matter of opinion. It is a factual issue that the PBMs, I will cite one other place to look, is there are actually 2 class action lawsuits that we know of that are in the public sector filed by Johnson & Johnson employees against their employer, Johnson & Johnson, because they selected a PBM that resulted in substantially higher costs for those patients of the employee health plan. They basically are saying, our company, which happens to be a drug manufacturer in this case, they contracted with a PBM that resulted in more expense for us as employees. Similarly, Wells Fargo employees filed a lawsuit that says basically the same things. Our employer contracted with a PBM that is charging us as patients substantially more than not just what another insurance company would charge us, but what a GoodRx discount card or Mark Cuban's Cost Plus Pharmacy. Employees of these companies are looking at their really expensive specialty drug and seeing that through their employee benefit plan, for a 90-day supply of this cancer drug, it's a generic drug, it's $16,000. The same exact drug for a 90-day supply at Mark Cuban's Cost Plus Pharmacy is less than $100 for that drug. And so as I said before, it's such the healthcare system with respect to pharmacy has so many layers that, should we have the time, we could talk through each of these separate issues and bring clarity. I want to stress that this is not so complicated that you couldn't understand it. There is a lot of information that you would have to digest, but when you hear it, you're like, well, that doesn't make sense. It wouldn't make sense in any other industry for it to work like this. That's perplexing that that's how the healthcare pharmacy system works. And to Kate's commentary, it's not that they're operating illegally, that they're doing illegal things that they're getting away with and nobody's prosecuting them. It's that there is not legislation on the books that prevents them from operating this way. And so we're advocating for, I'm personally, my personal views are that the government needs to stay out of my business. I don't support overreaching regulations. Find me an industry that's more regulated than the pharmacy industry, and I'll buy you dinner. Obviously there are some, but not many that are more regulated than pharmacy. But we lack oversight and we lack barriers to prevent pharmacy benefit managers from acting on these conflicts of interest that enrich them. That's basically the crux. Patients.
And Chris,
yes.
Yeah, Chris, why would a company sign with a PBM that they know would increase their costs are they getting kickbacks? What's happening?
Here's the issue. This is, the dirty secret is that the employers, they have a fiduciary response. This is what the lawsuits with these employers is related to a failure in their fiduciary responsibilities, but it's not because they knowingly make these decisions. They are not taking the steps to be informed about the right decision. And a huge part of the issue, which is cited in these lawsuits, is the broker, the benefits consultant and broker that is getting a kickback. So you've got brokers cited in this lawsuit the J&J lawsuit is Aon. Aon is a name some people might be familiar with. Maybe many aren't. If you're in this industry, you probably have heard of Aon. And there are other large global consulting firms that they're paid to advise employers. I do that with an independent firm in Pittsburgh, Henderson Brothers, which, unlike these other brokers, Henderson Brothers isn't on the take. Henderson Brothers doesn't take a kickback from the pharmacy solutions that we recommend. But in the case of these other employers, the broker tells the employer, this is who you should work with, and you pay us a lot of money for our opinion and our recommendations. So the employers are like, well, this is too complicated. I pay this broker. I trust them. So I'm going to make this choice. And then
so it's not the company itself that's benefiting. It's the broker who may be involved in some way with the PBMs that's advising, giving them bad advice that hurts their customers.
Right. And then you have employers that then are forced, you know, that scenario that Maria described where that $20,000 in copay assistance, the employer is taking that $20,000 and using it to lower the employer's contribution and not giving Maria credit towards her out-of-pocket costs. And in part, I help employers set up those programs. I know how they work in great detail, maybe better than most people in the United States. I can speak to this with great knowledge because when I'm wearing a hat to the benefit of my client, the employer, we are in an arms race with drug manufacturers. And it's like the employer is battling the drug manufacturer while the PBM is kind of sitting off to the side making money from everybody. And the patient is collateral damage in these scenarios. And so I can totally defend Maria's position and come up with a way to benefit Maria and other patients like hers. I can wear the hat of the employer that's trying to, you know, avoid increasing costs and passing on higher premiums to their employees. Some do it better than others, but the system, the most broken cog in this complicated system is the pharmacy benefit manager, which, because of their tactics, are causing gross waste, drug pricing inflation, all things that benefit them, by the way. When Maria gets prescriptions that the mail order pharmacy sends her that she doesn't need and she throws them in the trash. I'm not saying she does this, but I've had patients come into my pharmacies with $25,000 worth of drugs that they receive from their mail order pharmacy, which is owned by the PBM, that just kept sending them medication. And they came to me and said, hey, my spouse or my parent, they passed away. This medicine was in their cabinet. Can you do anything with it? Can you use this? And I said, well, no, it's illegal for me to take this, but we work with the local police department and we'll destroy this medicine. But it's literally $25, $50, $100,000 worth of drug that is getting thrown away. Well, guess who benefited from that?
Right. Well, let me do this. Let's bring in some other. But one of the things too that I still want to understand a little bit better, because just from the patient point of view, which is where I would sit, you were being asked to let people come into your home from a company that they wouldn't tell you where the company is located and how you could check out to make sure. Is that correct? There was no way you could verify and be able to trust people who would be coming into the home with your children.
Absolutely not. There was no way to verify who these people were. They wouldn't even, like I said, well, will you give me names of who you're sending? Will they have badges? No one would tell me. They said, no, we reserve the right. Sometimes we do send people, sometimes we don't. And I can say personally myself, years ago, before the ACA came into place, this was common practice for pharmacies to send in people to check on supplies to make sure we weren't, we were using as we were supposed to, not, stockpiling or anything like that. So I have had, I think twice and I want to say probably about 15 years ago, this happened where they came in, where they sent somebody.
Yeah, but Maria, then for them to do that, they have to be able to search your entire house at will, under your bed, in your, I mean, behind the toilet, I mean, they're supposed to be able to go anywhere in your house?
I mean, that's what they were asking, blanket permission for access to my records and to be able to check my medication supply. I never got clarification past that. They wouldn't give me anything further. They just told me either I had to accept what they were doing, or because, well, in my case, once I said no, I want more information, they took it as a hard no. They wouldn't let me even go back and say yes later on to get my medication.
So Chris,
So,
Kate, is this normal what we're hearing here?
Oh yeah, it's actually very normal. And here's the other thing, and Chris may know more about these programs than I do, but it seems that PBMs throw up barrier after barrier after barrier, and when one thing goes away or is restricted, there's another thing that they implement, and one of those more newer things is called alternative funding programs. And Chris, do you know about AFPs? So you correct me if I'm wrong, but I know that we've started working on this with patient groups, because what happens is a PBM will go to an employer and say, hey, we can save you money on your insurance costs. We're going to have you work. All you have to do is work with an AFP, an uh, alternative funding program company, through this company. So the insurer who wants to reduce the employer who wants to reduce insurance costs, and I'm going to digress for 1 second. Let's be really clear about one thing. Anybody who says they're trying to reduce insurance costs, no matter what happens, you have it happen, I have it happen, my premium goes up every single year. Okay? So, anyway, so the employer will say to the PBM, okay, great, I'll do that AFP. So then what happens is an outside company contacts the patient and says, your medication is no longer covered under your company's insurance plan, but we'll help you pay for it. We'll help you get funding for it. And what they do is they say, we'll get you copay assistance through maybe a charitable organization, or they'll go to an international pharmacy. Okay. And they may or may not tell you that that's what they'll do if they can't get it through assistance through a charity program. And but in order to do that, you have to turn over your annual income, all these private, all your assets, all this private information about yourself, in order for them to do that. And if you don't, you just don't get any kind of assistance. And if you do turn it over, you still may not get any kind of assistance, in which case then the employer plan does have to, I believe, have to cover the cost. But if they get assistance from either a charitable group, or say they can't get that and they go to an international pharmacy, that's incredibly dangerous. Okay? Because, as the FDA has jumped all over this. There's so many counterfeit medicines coming in that, and I'm not talking about fentanyl or anything like that. I'm talking about counterfeit medicines. And so it's dangerous to
and
have that
on
happen.
another note that is, I mean, specific more to the copay accumulators and maximizers, a federal judge has found them to be discriminatory, and they're actually banned on federal policies because of
Yes.
the fact they were found to be discriminatory against people with health conditions.
Yeah.
Mhm.
But
But
yet
there is
they're still,
also,
but we're not allowed to be protected like that.
Let me
right.
bring Reverend Strauss. Reverend, did you have any questions you wanted answered? I know you haven't had a chance to weigh in on this.
Not at the moment.
Sure.
I'm still trying to digest all of this. This is I guess, well, there was one thing that popped into my head. There's been some attempts to try to say, okay, we're going to do something that will limit what people have to pay out of pocket. And I'm thinking, right now the limits that have been placed, let's say on insulin. And how does that affect things? Or do these PBMs find other ways to supplement what they get when any kind of other limitations are put on what someone may have to pay out of pocket?
Yeah, I think that it's understanding how PBMs make money is an important part of the equation. So PBMs, they have several sources of revenue, and this is ignoring the fact that as a vertically integrated, company, meaning they're in the pharmacy benefit space, they have retail pharmacies, they have a mail order pharmacy, they have a specialty pharmacy. Each of those business units has their own way of profiting. But as a PBM specifically, they make money by charging fees to the employer, which is really the best way for them to make money, in my opinion, provided those fees are transparent and they are reasonable and fair, right? It's fair market value is a process used to determine what you would charge somebody for something. It's what is the cost, et cetera, et cetera. So charging fees is one way to make money. One of the other controversial methods of profit that harms pharmacies substantially is a practice called spread pricing. Spread pricing is where the PBM in the middle, when I process a prescription for a patient, I process that claim in real time, electronically, within seconds, less than a second. I submit a claim for Sally, it comes back, and I know that Sally has a $50 copay for her medicine, and the PBM is going to pay me $100. So $100 from the PBM, $50 from Sally, that's $150 I'm going to get net for that transaction. Well, that same transaction, the PBM is paying me, but before they pay me, they take the money from the plan sponsor. Because again, the PBM's in the middle. They cut me a check, but before they cut me a check, they take the money from whoever's actually paying the bill, meaning the self-insured employer or the federal government or Medicaid. They have to get paid first before they pay me. And for that same transaction, that was $150, $100 from the PBM and $50 from the patient, they show the plan sponsor a much larger number. So the employer or Medicare or Medicaid, they pay the PBM $300. And then the PBM passes on $100 to me, and they keep $200. So that is called spread pricing, where the payment to the provider is less than the charge to the plan sponsor. Earlier, I said the PBM bears no risk. Like, they're not taking any risk on that money. They certainly won't pay me less than they collect from the plan sponsor. But mostly, and this is where we got into those issues around Mark Cuban's pricing. Well, the PBM benefits from higher drug prices because there's more spread for them to take. The other critical area where PBMs get profit, and this is really what's been slammed by Congress, by the FTC, is drug rebates. So the pharmacy's out of the equation on the drug rebates. Now you have the drug manufacturer and the plan sponsor. So when a health plan, pays for a brand name drug, the manufacturers have negotiated post-sale discounts. They're called rebates. So the drug manufacturer says, I'm going to sell you this drug up front for $1,000, but when I confirm that you bought my drug for $1,000, I'm going to give you $400 back. So the manufacturer nets that transaction at $600 because they sold it up front for $1,000, but then they gave $400 back to the company that paid for the drug. Well, the PBM is taking a piece of that pie. So manufacturer, they sold the drug for $1,000. Now it comes time to pay the rebate. They give $400 to the PBM, but instead of the PBM giving $400 back to the employer, they give them $200, and they keep $200 in the middle for their troubles. guess what? Just like on the spread pricing, the company that's paying the bill has no idea what the pharmacy was paid. What for the rebate, the employer that's getting the 200 has no idea what the PBM was given by the drug manufacturer. And so there's no transparency to who got what. And the $400 rebate that the manufacturer pays the PBM, that is negotiated for placement on the formulary. When we wonder, there are a bunch of drugs to treat the same condition. Which drug is preferred? Which drug is first? Which one is not on the formulary? Well, that negotiation, yes, in a lot of ways, we view that as clinically based, like what's the best drug? Most often, it's about which drug is going to generate the most money. And when you talk about $35 insulin or whatnot, there are multiple ways to skin the cat. And those are just literally, because we're at time here, those are only two methods that are leveraged for profiting. And it doesn't consider probably 6 or 7 other levers that can be pulled to generate profit. There are manufacturer fees.
The drugs are generally assigned by the physician, right? The physician.
Yeah, but the physician prescribes it, and then when they go to the pharmacy, if the prescription's not covered at the pharmacy counter, the physician has said what is covered, because in most conditions, in most conditions, you have several options. The PBM decides which.
Okay, Reverend Strauss, you
I just have one quick follow-up. It seems to me that a huge response or an answer to this is to force transparency. Is that part of the legislation to make sure that people can actually see what's going on in all of this? Because we obviously don't.
The short answer is yes, there's legislation pending in Congress in various committees. Nothing has passed. And
not federally.
Haley, I don't know if you can speak to this or not, but I will tell you that the reason we asked for this Ed Board meeting is because of the urgency of it. Now, there's a few pieces of legislation in the Help Committee, which Senator Casey is on. That was the initial my email to you, Joyce. But there are pieces of legislation in various committees, and none of it gets moved. And if Congress doesn't act by December 20th, when it shuts down, that's another year that at least that will go on where patients are suffering and where drug discounts are not passed along to the patient. And in Pennsylvania, I think Governor Shapiro in his State of the State last year talked about how 1 million people in Pennsylvania suffer from medical debt. And these, the PBMs are a huge reason why. Nobody, as Chris said, there is no oversight. And so there is legislation pending, and it's urgent that our federal lawmakers take action to protect their constituents.
And the reason that the pharmacies get hurt by this, just so I'm clear, is that the PBMs are directing them to specific pharmacies that benefit them, that they may own. Correct. Is there another reason pharmacies are being hurt, Chris?
The primary issue is that they are paying my pharmacy less than what I purchased the drug for. So CVS Health, and this is the dynamic that is hard for people to understand, that it's legal. In order for me the majority of Americans have some type of insurance. The majority of my patients that I serve are underserved. Medicaid, Medicare, they tend to be more in need of services that we provide, like home delivery, like special packaging, like 24/7 emergency services and whatnot. All the extra things we do benefit the most needy patients. That's the niche of most independent pharmacies in their communities. And in like Medicare is any willing provider. If they can't force a Medicare patient to go to a specific pharmacy like they can a commercial patient. But how do they benefit? Well, if that transaction where I gave the example of the 150 versus 300, that drug could cost me $200 or $250, and I'm underwater on that transaction. Well, guess what? CVS benefits by paying me less and increasing their spread. And then what happened was years ago, that hasn't happened recently because it got national news. They underpay me because guess what? They know what drugs cost. So they know very likely what I actually bought the drug for, and they pay me under it. And then I get a letter from CVS that says, times are tough. You should consider selling your pharmacy. And so it's basically they squeeze their competition because in order for me to service patients, I have to have a contract with the PBM, and it's a no negotiation contract.
So you have to have a contract with the PBM that owns a pharmacy that's competing with you, and they're paying you less for the drug, meanwhile telling you might want to sell to them at a reduced.
Exactly.
Wow. Okay, I think it's
making
sense. I think it's
no, and don't forget, Joyce, don't forget, as Chris and Haley alluded to, the concept of vertical integration. These companies, one company owns the next company, owns the next company, owns the next company. They're all getting part of that. And guess who's not getting it? The independent pharmacist, and most importantly, the patient.
Right.
So my we do have to wrap it up because we've covered a lot of stuff. But one question I have is, in Pennsylvania, there's something that you want done, and nationally, there's something you want done. So clarify that, and who's supporting you and who's not supporting you. So I don't know who wants to take that.
Joyce,
I got it. I can help. Go ahead.
Well, I was just going to say, in Pennsylvania, there was a copay accumulator bill that ran through, and you did an editorial board meeting with us, with a couple of other patient advocates earlier in the year. And that bill didn't go anywhere. It'll come back next year. That was specific to copay accumulators. At the federal level, there are bills that are pending that address a number of these issues. But what Chris said is probably the most important thing is the transparency, to make what PBMs do, to make them transparent. There is no transparency. And now I'll turn it over to Haley.
Yeah, kind of echoing what Kate said. I've never heard of a PBM until I started getting involved with this work. Again, I just got off my parents' insurance, so that might be a reason why. But I think what's most important is echoing what Chris and Kate both said, requiring transparency in what these PBMs are paying for drugs and where these rebates are going and how they're not being passed off to the consumer. I think also addressing the oligopoly and requiring breakup of these companies. Now, vertical integration in which like the insurer or the company owns another thing. I work with UPMC, which is also a vertically integrated company, but requiring these companies to sell back some of their pharmacies and some kind of legislation or a process through the federal government, if possible, to break up these monopolies and reduce the tremendous market share that those 3 PBMs that I mentioned earlier have. So that will increase competition, increase the number of pharmacies and other individuals in the market, and therefore reduce costs for patients. And I do know there are some federal legislation, as Kate said, at the state level in Massachusetts. And once again, in addition to Bob Casey, the Massachusetts representative, Jake Auchincloss is also doing work at the federal level for PBM reform. So I think just requiring transparency in what these companies are paying for and reducing the market share through breakup of these large companies and reducing vertical integration that way is a way to address these issues and bring cost savings to consumers.
I guess the reason I ask you that, just to zero in that, I see that Sandy also put that she had to change her Medicare D plan because the plan was every option wanted preferred pharmacy, and you wanted to continue using your local independent pharmacy. So you had to make sure you were aware of that. Right. But the question that I also, I just don't understand why anybody would be opposed to this, why it wouldn't get passed. But I mean, what is the political block here? It
Yes.
just seems to make sense for the voter, right?
I apologize because I'm going to have to drop, but I would make two comments, Joyce, for that. One is to piggyback on what needs to be done. We need to recognize where conflicts of interest exist, and we need to prevent those conflicts of interest from materializing. And that will only occur when it's transparency, in my opinion, is not enough. You can't, just by knowing where the money is going isn't going to change the fact that there are conflicts of interest that are driving primarily anti-competitive practices and that incentivize waste and price increasing. That's something that has to be addressed. And I think Haley's comments around, eliminating, like, you can't be a PBM and own a pharmacy. You can't pay your own pharmacy. This is an important component. But the opposition is that the PBMs are very rich.
Yeah.
And they have lobbies that argue that what they do is actually saving money. And if you take away their power, you will cost the system more money. This is obviously refuted in great strength by the FTC and other individuals. Look, you can see that there are examples of, whether it's at an individual employer or whether it's at a state level. We've seen some action in various states. The state of California made some sweeping changes, West Virginia, New York, Kentucky, other states. And then you can look at it at the federal level with federal regulators. The Supreme Court has weighed in a lawsuit filed by PCMA, which represents PBMs, and the Attorney General of Arkansas. And so there's tremendous evidence to support that what they state with respect to cost savings is just not true. So I appreciate the opportunity to be here with you all. I apologize I have to jump, but hopefully this was helpful and we can talk again. Thank you.
All right. Well, I think if you want to follow up, Kate, with some maybe bullet points of here's what the action is I think you did that in your initial thing, but if there's anything more you want to add, please do that. Is there any, I mean, Jeffrey, I know you came in a bit late and I'm sure all of this is a bit overwhelming, but is there anything you wanted to ask or okay. All right.
Luckily for Jeffrey, it's recorded. He can watch the whole thing.
Exactly. He'll be able to because we did cover a lot of ground here. But I think we've got a very clear understanding of this. So if there's anything else, you know how to reach me to clarify or to add any links, especially you mentioned several of the I'm going to look for the FTC a statement of their grave concerns.
I think I can send that to you. I think I have that. Right. I wrote that down. Good. I'll try to send that to you. And I think there have been, lots of studies and lots that's been written on how I think the biggest part, is that these PBMs have tremendous amounts of money to spend on lobbying the lawmakers, and lawmakers have a duty to represent their constituents, who are the patients, who are the pharmacists, and they're not doing it. And that's kind of egregious, if you ask me.
Okay, Maria, you had a final thing you wanted to say?
Oh, no, I was just going to say follow the money, like she said, where,
right.
If you go into look at some of the people that are running our government and look where their funding comes from, you can kind of see why it's very difficult to get anything like this to move forward.
Yeah. Okay. And I see Haley says Pitt does a lot of research on drug costs and has a Medicaid research center. Okay. Which can be helpful. Good. Well, any link you can give, that would be,
The last thing I would like to say is all you have to do is look at Mark Cuban's company and see, you get a very clear picture there about how much PBMs are increasing the drug prices.
Mhm.
You know, people think that it's drug manufacturers or hospitals or whatever they think. But if you follow what we've laid out here for you today, it all comes back to the guy in the middle, and that's the PBM. And so, you know, if you look at Mark Cuban's site, and it's right there, the difference in the cost. It's thousands and thousands of dollars per prescription.
Amazing. Well, thank you. Thank you very much, ladies, and the gent who left for joining us. And thanks to the editorial board for delving into truly a complicated topic, but one that affects so millions and millions of people, and that eventually affects us all. So
Exactly.
thank you again.
Thank you
And
for your time.
we'll be looking forward to writing something about this topic. So enjoy your day.
Thank you.
Bye-bye.
Thank you.
Thank you.